What's up, guys? What's happening? I'm so excited today. There is a new playlist, a new series of lecture, Pulmonology, the wonderland of the lungs and your chest wall and the pleural cavity in between with its negative intrathoracic pressure. If you are willing to put in the time and the effort, you are becoming an expert in this field of pulmonology, and you will never regret it. You'll be proud of yourself forever. Because you know what? You go to first year medical school and your miserable anatomy professor overwhelms you with trivial details about origin, insertion, nerve supply, and action, not to mention relations. And you don't understand why are you even learning this. Then you go to your pathology classes or path, and the psychopath professor convinces you that life is not pink and rosy, it's full of pain and suffering, and the only pink you're going to see is under the microscope in histopathology. Then your sophisticated pharmacology professor, with his theories, comes in with his receptors and pathways and makes you want to do drugs. Don't do it. Then you go to the internal medicine lectures and you have already forgot what the normal was and what the disease is. And here comes this guy with a stethoscope telling me that I can diagnose it and treat it. Every professor is living in his own cocoon and they don't talk to each other. What if there was a better solution? What if there was a weird Egyptian guy sitting in his kitchen and he can explain all of this to you and connect the dots together? This is the story of Medicosis Perfectionalis. It all starts in the kitchen, and let's get started. I wasn't planning on doing pulmonology lectures this year until this mysterious guy who I never met came to me. Let's call him Dr. Joe. And he said, you know what, my friend, I'm willing to support this channel. I'll put my money where my mouth is. I would like you to produce some excellent pulmonology lectures and I'm gonna pay for it. Can we make a deal? Of course, I said yes. Thank you so much, Dr. Joe. And if you are watching this video, please take 5 seconds to say a thank you to Dr. Joe, because this playlist is only possible because of his generosity. So, if you wanna support this channel, please do it, and let's get into pulmonology. If the foundation is good, everything will flow logically and everything is gonna be fine. So, the basics first. We'll talk about anatomy, histology, pharmacology, pathology, and then physiology. We'll start with the upper respiratory tract and go downwards. Then after the physiology, we'll dive into the land of pathology and internal medicine and how to diagnose asthma, how to treat asthma, how to diagnose COPD and classify it, and how to treat it. All of this we're going to discuss. It's going to be amazing. So, anatomy, we have 2 videos. In this video, I'll talk about the thoracic wall, which is made of bones and then muscles. Bones, we have thoracic vertebra, ribs, and sternum. Muscles, we have the famous diaphragm, the most important one, and then the intercostal muscles, we have internal and external. And then we'll have cases after this video. In the next video, we'll talk about soft tissue. Before the lung, we have the tracheobronchial tree. Between the lungs, there's something called the mediastinum, and then the lungs themselves. Around the lung, there is the pleura, and then some lymph nodes and some Virchow's node or Furco, like this, which is really important. All right, now let's get started. The thoracic wall, first vertebral column. All right, after the 7 cervical vertebra, we have 12 thoracic. The bodies of the vertebra 5, 6, 7, and 8, all right, are in contact or related to the descending thoracic aorta. Here is the aorta coming out of the heart. Here is ascending aorta, the aortic arch, and then descending thoracic aorta, then the descending abdominal aorta or abdominal. If an aneurysm happens in this descending thoracic aorta, it can press on the bodies of T5, 6, 7, and 8. And here is the interesting thing. It erodes the vertebral body because it's vascular. This is called pressure atrophy, and it's visible on X-ray, but it doesn't touch the intervertebral disc. Why is the disc not affected? Because the disc is avascular. Remember, cartilage of any type is avascular. And the whole idea of pressure atrophy is that you press on the tissue, occlude the vessel, deprive the tissue of blood supply, and causing ischemia. Since the bodies are vascular, if you deprive them of their blood supply, they're gonna suffer. But the disc doesn't care. It's already avascular. So aneurysm affects the vertebral body, but not the disc. How about metastasis? Same freaking concept. Metastasis comes through the blood. Fine, especially if they are sarcomas, because sarcomas love the blood, carcinomas love the lymph. And I've talked about this in my hematology playlist. Metastasis is gonna affect the vertebral body because it's vascular, but not the disc because it's avascular. So, aneurysm or metastasis, either one is gonna affect the vertebral body only and not the disc. Now, how about the crazy tuberculosis? First, affects the vertebral body, forming a tubercle. Group of tubercle together is called a tuberculoma, which is a granuloma. Later on, so first comes to the vertebral body. Why? Blood. And this is, by the way, a secondary TB, not the primary one, because the primary only affects 4 organs. Primary TB can affect the lung, the skin, the intestine, and the tonsil. Then, if you are immunocompromised, what will happen is this TB can be activated. Activated, yes. And then when it's activated, it can literally go to any organs. It goes to the vertebra. It starts at the body, and then it can even extend to the disc, forming something called cold abscess. Why cold abscess? Okay, normally, let's say you're a normal person, you're immunocompetent, and then you have an abscess due to an infection. You will have all the cardinal signs of inflammation: redness, hotness, swelling, pain, loss of function. You might even produce some pus. Why? Because your immune system is working. Your white blood cells are fine. But if you are immunocompromised, you don't have an immune system. You don't have your military called white blood cells or leukocytes. You cannot produce pus. You cannot produce redness, hotness, swelling, pain, loss of function. Your abscess is gonna be cold. And without pus and without any cardinal sign of inflammation, it's called cold abscess. The cold abscess can involve the body and the disc. TB is horrible. Second, we have the ribs. We have 12 pairs of ribs. Alright, ribs are weakest at their costal angle, especially just anterior to the costal angle, so here. Alright, because of the curve. You can have a street fight, this is called direct injury or trauma, or you can have a car accident, this is called crushing injury, or even strong hugging. So, if you're a muscular man, don't hug your babe too hard, you can break her ribs, dummy. I was trying to be romantic. This is not romantic, this is stupid. Direct injury due to a fight can fracture the ribs anywhere, and then the broken ends might protrude interiorly, leading to injury of the lung and even abdominal organs such as the spleen, and this is very important. You can have a splenic injury due to a trauma that broke the ribs. Crushing injury in a motor vehicle accident can break the rib at its weakest point, just anterior to the costal angle. The most commonly fractured ribs are the middle ones. Why? Because they are subject to trauma, they occupy the greatest surface area, and if I wanna hit you in the chest, I will never do this, but your middle ribs are just in front of me. Alright, so they are just more likely just because of their location. This is different from the first 2 ribs because they are partially protected by the clavicle, especially the first rib. It's very, very, very hard to break the first rib. Also the last 2 ribs because they are floating ribs, T11 and T12. Floating, they are freely mobile. You cannot hit them. Alright, so let me give you a very simplistic example. Let's say that you have a peanut or a nut or something like that. Here's the peanut, and you want to break it with the hammer in order to release what's inside of it. You don't just hit the peanut. No, it's gonna move everywhere. You use your other hand to hold the peanut in place, and then you hit on the peanut. That's how you break it. Same thing. It's very hard to break the floating ribs. Why? They are freely mobile. It's very easy to hit and break the middle ribs. Why? Because they are attached to the sternum in front and to your thoracic vertebral column in the back. Alright, let's say that we have fractured the middle ribs. Now what? The rib fracture, very painful, especially during breathing. Now they have penetrated your lung, you can't breathe in. This is called a pleuritic chest pain. A pleuritic chest pain is a chest pain that's related to breathing. It increases when you breathe. It hurts. And then exhale. It still kind of hurts. But then when you hold your breath, it doesn't hurt. But when you breathe, it hurts. This is called pleuritic chest pain. Pleuritic from pleura. It's related to the lung movement. Coughing, same thing. You're squeezing your lung. Sneezing, same thing. You're squeezing your lung with a positive intrathoracic pressure. As a response to this pain from the rib fracture, the patient will decrease his breathing for the fear of pain. Then he cannot fill his lung with adequate air because now he's afraid of the pain. He cannot do this. It hurts, so he does like this. This will lead to less air coming in, decreased tidal volume. We'll talk about this later. This is called restrictive lung disease because the lung is restricted from filling. When your lung is restricted from filling, this is a restrictive lung disease. Fun fact, it's not that fun. During CPR, cardiopulmonary resuscitation, you can break the ribs. Like really, I'm trying to save the patient's life and now I broke his ribs. How unlucky am I? What should I do? Should I stop the CPR? Shut up! Stop it! What? Don't stop. You continue. Because in life, the choice is not usually between good and bad. It's usually between bad and worse. You have two choices. A, the patient is gonna die. B, the patient is gonna live with broken ribs, which will heal eventually. Of course I'm gonna choose B, but the patient can take me to court. He can take you to court, but he's not gonna win. It's an emergency situation and you have saved his life. Shut up. Do the right thing. Be brave. And as Hippocrates said, do no harm. Leaving the patient to die for fear of breaking his ribs is what's known as stupid and malpractice. Now your age matters. If you're an infant or a child, your ribs are elastic, less likely to fracture. If you have fractured ribs in a kid without a car accident, beware of child abuse. And the federal whatever program or organization, association or whatever to call is the CPS, Child Protective Service in the United States. In the UK it's called something else, and it's every country something else. Okay, in America every 3 letters that you put together is gonna be a government program. You have the FBI, the FDA, the Housing and Urban Development, or HUD, the whatever, every 3 letters or something. In the elderly, rib fracture can be deadly. Deadly? Why? Because the pain can lead to hypoventilation. He's an elderly man. His lungs are already weak. Add pain equals hypoventilation. With hypoventilation, this is atelectasis, and can lead to atelectatic pneumonia. Management. Manage the pain. Local nerve block. Nerve block? Not just aspirin and non-steroidal? Shut up! He can die. Go radical. Local nerve block or epidural catheter. Rib fractures may or may not be visible on chest x-ray, so you need the history. You need the physical exam. Not just, the x-ray is normal, the patient is normal, he can go home. Shut up! You're a doctor, you're not a machine. Think. What's the difference between the chest pain caused by a rib fracture and chest pain caused by a heart attack, myocardial infarction, or angina, or whatever? First, the history. You have history of trauma, car accident, or even child or elderly abuse. Heart attack, you have risk factors of ischemic heart disease. We have the non-modifiable, such as you have the age, you have the sex, you have maybe some genes. Modifiable that you can control, so your weight, your stress level, your cholesterol, your diabetes, hypertension, etc. Patient described the pain as sharp, pointed. It's like a knife pointing inwards. Heart attack, it's not sharp, it's dull, squeezing, pressure-like, as if an elephant is sitting on my chest. Physical exam. Is the pain pleuritic? Yes. What does it mean? Pain increases on inhalation. Also on coughing and sneezing and stuff like that. How about this? No. The heart attack pain is not positional, not pleuritic, and not tender. Very important. Positional. Does the pain change with the position? Maybe. If you position the patient so that the ribs penetrate the lung more, it's gonna be more pain. Here, no. Tender, if you press on the chest, is it painful? Of course, the ribs are fractured, you idiot. And then on heart attack, no. Heart attack pain is not positional, not pleuritic, and not tender. Lab, EKG, normal, might be abnormal. Of course, if it's abnormal, you have your diagnosis. Stress test, it's unapplicable. The patient is having a rib fracture and you want him to run on a treadmill, you're stupid. Here it's abnormal. Cardiac markers normal, elevated troponin and CKMB. Let's do a chest x-ray. It might or might not show the rib fracture. Here x-ray is gonna be normal. Now please, I want you to focus on the flail chest because the flail chest can be fatal. Focus. Multiple rib fracture, not just one rib. It's not gonna happen with one rib. Part of the chest wall, especially anterior or lateral, again, because it's more liable to trauma because of the position. Paradoxical movement of this part of the chest. What the flip does that mean? Okay, normally you breathe in. With inspiration, your chest wall expands. And then you exhale. Your chest wall collapses, going inwards. Paradoxical is the opposite. This area of the chest where you have the flail chest, you have inward movement on inhalation, weird, and outward on exhalation, also weird. This will lead to decreased ventilation because the patient is trying to breathe in and expand his chest. But this area of the chest is collapsing instead of expanding. Of course, this will decrease ventilation, which means the oxygen coming into the lung and then into the bloodstream later decreases gas exchange, of course, because there is less oxygen in the alveoli. The AA gradient is normal because it's not the lung's fault, and we'll talk about the AA gradient later. The AA gradient is abnormal if it's a primary lung disease. Rib fracture is an external thing, it's secondary, it's not in the lung, so AA gradient is gonna be high. DLCO, the diffusion limit of carbon monoxide, is normal because it's not all the lung's fault. And then we have the PAFT, which will show a restrictive pattern because the lung is restricted from filling. How to treat flail chest. If these ribs are broken and they are causing hypoventilation and decreased gas exchange, fix this loose segment by hooks and or wires so that it cannot move. You fix it in its place. And then complications, death, fatal. Why? Because of the ribs? Shut up. Ribs what? Like because of the pain? No pain, no gain. It's not the issue. The issue here is called pulmonary contusion. It's horrible. The lung is very sensitive to fluid overload. The patient will literally drown in his own water. Mnemonic. Flail chest happens when you have frequent rib fractures. By frequent, I don't mean I mean many ribs, multiple ribs, not multiple traumas, just frequent ribs. Multiple, okay? You get it. Chest movement is effed up. That's why we have paradoxical movement of the chest wall. Can be fatal. Please fix the rib before it's freaking late. Let's have some surgical techniques. When I say thoracotomy, it means any cut into the chest wall. I wanna go into your pleura, go into your lung, go into your heart, whatever, and I opened and cut the chest wall. This is called a thoracotomy. To access the pleura, sometimes you have to remove a piece of the rib. For autologous bone grafting, remember, the patient needs a piece of bone for his leg forever. You can take a piece of bone from the rib and attach it in his leg. This is called autologous because auto means self, bone grafting. What's the fate of the short rib after excision? Let's say we cut a piece of this rib. What's going to happen next? It will regenerate from the remaining periosteum, which is awesome. This is very similar to the liver. If I cut like a third of your liver, or sometimes even half, your liver can regenerate back to its complete shape, which is amazing. Now, what kind of cell is the hepatocyte? Is it a permanent cell, stable cell, or labile cell? Please let me know the answer down below in the comment section. Accessory ribs. Normally you have 12 pairs of ribs, so that equals 24, at least where I grew up. But some people have a pathology called accessory ribs. Could be in the neck, called cervical rib, or you can be in the lumbar rib. This is extra rib, called accessory ribs. Did I just say extra ribs? Sorry, I work in a restaurant. So we have cervical, extra rib attached to C7 vertebra. C7 is the last vertebral body in the cervical vertebral column. Isn't there such a thing as C8? There is a C8 nerve segment, but not a vertebral body. Get your head out of your sphincter. It's usually asymptomatic, but it might cause neuro, which means nerve, vascular, which means vessel, compromise in the upper extremity. This is called thoracic outlet syndrome. Okay, this is a stupid name because where I grew up, this was called the thoracic inlet and this was called the thoracic outlet. For some reason, they call this part in above when it has a disease thoracic outlet syndrome. How about this when it has a syndrome? There is no syndrome down there. So the one above, we can call it thoracic inlet syndrome. It's correct. Or thoracic outlet syndrome. It's also correct depending on who is the jerk that's writing the textbook. I'm sorry. Thoracic outlet or inlet syndrome. Compression of, are you ready? Lower trunk of the brachial plexus, sympathetic chain, and even the subclavian artery. Causes cervical rib or maybe a lymphosarcoma. Alright, lymph node, crazy lymph node here that has cancer. And of course, cancer is painless, infection is painful. Neurological symptoms, of course, because you've damaged the nerve, especially the lower trunk of the brachial plexus. You have weakness of the muscles of the hand, so it's a distal problem. It's not a proximal in your shoulder or here. It's a distal problem because this is the lower trunk, if you remember your anatomy. And this is very similar to clump case paralysis. Sensory, you can have numbness and tingling in the finger. Again, it's a distal problem because it's the lower trunk. Why not the upper trunk? Because the lower trunk is here passing between the cervical rib and the first rib. The upper trunk is up there. It's fine. Ipsilateral Horner syndrome. Why? Pressure on the sympathetic chain. Ptosis, meiosis, and hydrosis on the same side. How about vascular? Why vascular? Because you have pressed on the subclavian artery. Your limb is cold, pale, has cyanosis of the hand. Positive Addison's sign, not Addison. Get your head out of your adrenal. Okay, it's positive Addison sign. What the flip is that? You ask the patient to abduct and externally rotate the shoulder. And then you measure the radial pulse in his hand or wrist. And it's lost. What? Because when you ask the patient to abduct and externally rotate, you have effectively pressed on that subclavian artery to the fullest. And as you know, the subclavian artery is going to be the axillary artery, then it's going to be extend more to be the brachial artery, then it's going to be the radial artery. So if you press on the origin, you don't have what the consequences. Not specific for cervical rib, this Addison sign. So some individuals without a cervical rib can still have a positive test. Example, how about the crazy lymphosarcoma? Yeah, baby. Ankle brachial index may be high, theoretically, because we don't do it for thoracic outlet syndrome, but if your blood coming to the upper limb is less than the blood pressure in your ankle, this is gonna lead to a high ankle brachial index, and we're gonna talk about this guy in cardiology. Unequal pulse volume in right and left arm. Measure the radial pulse here. Not the heart rate, I mean the volume. Is it strong? Does it like shoot in your hand and you feel it strongly or weakly? And then put your hand on the other arm at the same time and feel it. It's unequal pulse. Unequal blood pressure between right arm and left arm, of course, because you have pressed on the freaking subclavian artery. The systolic pressure difference between the right and left is going to be 15 to 20 between the two. Normally, it's 10 or less. 15 to 20 is abnormal. Take it to the bank. Lymphosarcoma can cause neurovascular compromise. We already know that. Plus venous congestion in the upper body and the upper extremity. Lumbar rib. Now, lumbar rib is fun. Why fun? Because it confuses medical students. So if you're radiology, you want to be funny, all right, and sound facetious and make fun of you in front of anyone else, the lumbar rib is a classic example. And it goes like this. So, by the way, it's more common than the cervical rib, and sometimes you see L1 usually has not a rib but a transverse process. This is normal. Now in some patient it can have like a lumbar rib and it looks like this. So sometimes the student, like when you see an x-ray, first thing you have to count the vertebra because you want to determine is this T11 or T12, and this is T12 and this is L1. So the students will say, okay, the last rib comes from T12. So this one is going to be T12. And then your radiologist is going to start laughing. Ho, ho, ho. No, honey, this is L1. But it has a rib. Yes, that's a lumbar rib. And now everybody's going to laugh at you, and even the nurses. And then next trick. If your radiologist want to trick you as a medical student, he can ask you, you see this? What do you think this is? Then you'll count, okay, now I know that this is T12 because they have just laughed at me, so this has to be L1. This might be like a fracture of the lumbar transverse process, and he will laugh again because it's not a transverse process, it's a lumbar rib. But since the transverse process usually looks like this and the lumbar rib looks like this, you might imagine that this is a fracture. It's not, it's a rib, okay? Coarctation of the aorta. Alright, in some babies, normal aorta looks like this. In some people, the abnormal aorta looks like this. This is a stupid drawing. Alright, this is called coarctation. Alright, so what's gonna happen? Blood supply to the lower extremities is going to be compromised because the aorta is thinner. The pressure here is going to be high. It's going to open some anastomoses that were normally closed. And this anastomosis will go to the chest. Hopefully is that we can bypass this obstructed flow and give blood to your lower extremities so that you may live. This is called a collateral circulation. And these anastomoses pass by the ribs. Sometimes they can cause notching of the rib. Why notching? Because there is blood passing by at increased pressure. It's very similar to pressure atrophy. So don't forget, coarctation of the aorta can lead to notching of the ribs, and you see it beautifully on X-ray. Here is a trick question. Notching of the rib. Let me draw a rib for you. So let's say that we have a nice rib like this, and it goes all the way around until it reaches the vertebral column. Notching of the rib is gonna be, alright, it's gonna be notch here, another notch here, another notch here, another notch here. How about here? Will you have a notching here? The answer is no, because this is the costal cartilage, and cartilage is avascular. You cannot cause pressure atrophy on a cartilage. Next we have the sternum. Sternal fracture. Again, it's very hard to fracture the sternum. There are 3 chest bones that is very difficult to fracture. First rib, as I've told you before, it's covered by the clavicle, scapula, and sternum. If you see fractured sternum in a patient, don't say, okay, you have a fractured sternum, I will repair your sternum and everything is gonna be hunky-dory. Shut up. Look for a hidden disaster waiting to happen, such as traumatic rupture of the aorta. Why? Honey, it's very hard to break the sternum. If you find sternum break, it means the trauma was immense. And it's usually a car accident. And you know what happened when you are driving your car at like 75 miles per hour, or I don't know what, this is like 120 kilometers per hour, and suddenly you hit something, you will stop. But then you have inertia. Your body is trying to continue its motion at the same previous speed until you hit the airbag or whatever, or you hit the dashboard, and then you're gonna stop suddenly. This is called a deceleration injury, which is opposite to acceleration of the aorta. The aorta has a very weak part at the junction of the aortic arch and the descending thoracic aorta. So let's do it. So here's the arch and here's the aorta. This part is very weak. With deceleration injury, this part can break. And when you bleed from your aorta, it's never gonna be fun. First, this bleeding collects like this beneath the adventitia of the aorta. If you're a good doctor and you see a patient with fractured sternum, you gotta suspect the traumatic rupture of the aorta and do the test. Don't wait for the patient to die, because he will die in a second. And surgeons will call this the ultimate hidden injury, because the patient is usually asymptomatic until he dies. Next, cardiac contusion. The trauma was severe. It can contuse your heart and your lung, called pulmonary contusion. We'll find white out on the chest x-ray and deteriorating arterial blood gas. Bone marrow aspiration. The sternum is a great source of red bone marrow, so the hematology oncology guy loves your sternum because it has red bone marrow, and red bone marrow is rich. Thoracic surgery. In case of cardiothoracic surgery, let's have you need an open heart surgery, and this is your heart, but your heart is covered with the sternum. You want to access your heart. They break the sternum in half, those bastard called surgeons, and then they can access your heart. They separate your chest right and left at the midline of the sternum, so they break it vertically. They do not break it horizontally. This is not a C-section. Get your head out of your sphincter. Pectus excavatum, also known as funnel chest. What a terrible name. So let's say that we have a patient. Let's draw a normal person. All right, here's the left breast, or the left part, and here's the right breast, and here is the sternum in between. Everything is nice. But if it's pectus excavatum, you will have a groove. Like, I don't know how to draw a groove, but it's this part is protruded inwards. It's like a funnel, as if you can pour water in this like cleft or ridge and the water will hold. What a terrible name. Funnel chest. Who are these people? Normally the sternum projects anteriorly and inferiorly, like this, and slightly to the back. So here is anterior, and here is posterior. So anteriorly and inferiorly like this. But now in pectus excavatum, the sternum projects inferiorly and posteriorly. So the sternum becomes like this. And this is your skin. So your skin will have a ridge because there is no bone underneath. You can pour water here. It's called the funnel chest. What a terrible analogy. Diagnosis, physical exam, of course, you'll see inward indentation. You put your fingers here above the sternum, and your finger is going to dive deep in. This is called pectus excavatum. In radiology, the heart appears wider than normal. You know why? Because this is the sternum, and this is the heart. Okay, just posterior to it. When the sternum presses on the heart is going to widen. If you're an idiot, you'll look at the x-ray. Hey, this heart has cardiomegaly. This patient has heart problem. Shut up. It's just the sternum pushing forward on the heart. What's the solution? In order for the radiologist not to make fun of me. Okay, the solution is to not only look at anteroposterior or posterior-anterior chest x-ray, but you also look at the lateral view. And when you look at the lateral view, you will realize that the heart is even smaller. It's not cardiomegaly if the heart is enlarged only in one direction. You need to think 3D. Pectus carneatum or carneatum is the opposite. It's an outward protrusion to the sternum. So if this is the normal sternum like this, the sternum is protruded outwards like this. All right, and the surrounding chest is gonna be flat, of course. So you have bulge in the middle, and then the surrounding right and left is flat. Named because it's similar to the keel of the boat. So let's say that this is Titanic, and we are looking at it in an anteroposterior fashion. So here is the bottom of the ship, and here is the other side. Here is the nice water. All right, water from here, and here is the ship. We're looking to it anteroposteriorly. Use your imagination. This part of the ship is called the keel. In Latin, this is called the carina. So pectus carneatum or carneatum is when you have a keel like this. So the sternum is bulging forward. When you put your finger here, you feel the bulge. And then right chest and left chest are flat. Got it? Okay. Same thing with the carina. You have the trachea here, and then it has right and left, and this part is called the carina because this looks like this part of the ship, but it's inverted. Okay, you get the idea. Stupid names. Diaphragm is the most important respiratory muscle, but it's not essential. Translation, you can live without it. It's not fun. You're not going to be able to run a marathon, but you can still live. Why? You still have your intercostal muscles and your abdominal muscles. Life is going to be tough, man, but you can do it. Paralysis of half the diaphragm, no problem, because you still have the other half thanks to separate nerve supply. So here is one copula of the diaphragm, and here's the other copula of the diaphragm, and they do the stuff. Okay, this has one nerve supply, this has a separate nerve supply. If you have a nerve paralysis in this one will survive, and you will live. That's amazing. Tumor will infringe, if a tumor infringes on the phrenic nerve, you have paralysis of the diaphragm, you cannot breathe in. Restricted from filling, leading to a restrictive lung disease. And this is one of the causes of restrictive lung disease, as we'll discuss later. Remember, when you can't get the air in, we call this a restrictive lung disease. When you can't get the air out, we call this an obstructive lung disease. And this is going to be really important, okay? This is very simplistic, but it's actually true. Flat diaphragm is seen in emphysema or COPD. We call this barrel chest. Your chest expanded so much and it pushed on the diaphragm, it's as if your chest is like a barrel. And normally, if we are doing a CT scan and this is a cross section of your chest, normally you look like this. Here is a lung and here is a lung. If you have a barrel chest, your chest looks like this. It's like a barrel. It's more circular. This diameter has increased and this diameter has increased. If you want to get a sample of fluid in the pleura, pleurocentesis, you can insert the needle in the 7th intercostal space. But be very careful, because lower than that, if you go deeper, if you're stupid, you can injure the diaphragm, and then you can continue on to the liver or the spleen. Don't be an idiot. Intercostal muscles. Your chest wall is like a bucket. External intercostals and internal intercostals. So let's say that these are the ribs. What happens during inhalation? Your chest expands. So these are the external intercostal muscles on the outside. They will lift your chest upwards. So the external, the one on the outside, are responsible for inhalation because they expand the chest. Other muscles beneath them on the inside are called the internal intercostal muscles. The internal intercostal muscles will pull your chest inwards, and they are responsible for exhalation. But the forced exhalation, not the normal, because normal expiration is passive. You don't need your muscles to exhale. You only need your muscles to inhale. But then exhalation is going to be passive. Why passive? Thanks to the lungs' elastic recoil. Cases, baby, we have 2 cases. A person was stabbed by a knife into the anterior chest wall. The knife penetrated straight forward to the heart. So, which of the following chambers were more likely affected by the knife? The video is not over yet. We still have the second case. If you are struggling to learn about Legionella, Mycoplasma, Pseudomonas, Rhinovirus, Staph aureus, Streptococcus, all of this stuff is crazy, but Picmonic will have pictures and mnemonics, and it's like animated with videos and characters. It's really fun. I've learned microbiology and pharmacology from Picmonic like 4 years ago, and I still remember those video and those animations. It's actually freaking amazing. And I will leave the link in the description below. Second case, you have a 59-year-old male who was involved in a head-on collision while driving at a speed of 75 miles per hour. That's over the speed limit. You're gonna get a ticket from the police officer. But anyways, let's focus about medicine. The airbags were deployed. Oh my god, the insurance company is gonna ask about that. His sternum was fractured. Ooh. He was recovering in the ER, and his vital signs were within normal limits initially. He was hemodynamically stable initially. Initial arterial blood gas, pH was 7.31, PaCO2 was 47, and then HCO3 30, PaO2 93. ABG 24 hours later, the pH 7.26, the PaCO2 is 55, bicarbonate is 34, and PaO2 is 8. Let me make it easier for you. Let's add in the initial ABG. The oxygen saturation was 97%, and then 24 hours later it's 94%. A posterior-anterior chest x-ray was ordered and showed white out of the lung fields. Then we have 2 questions. What's the most likely diagnosis? Question number 2, what's the best management approach? So here is your homework. Answer case number 1, answer case number 2. It has 2 questions. Let me know all of this in the comment. Mention causes of pectus excavatum, mention causes of pectus herniatum, and write a thank you note to Dr. Joe down below in the comments. And if you want to support my channel on Patreon, I'll be eternally grateful. Your support is how I put food on my table, and light in my bulb, and textbooks on my shelf. Thank you guys. Do you like this pulmonology playlist? Let me know in the comment. Subscribe and hit the bell to get notified when I release the next video, and it's gonna contain the answers of today's cases. You can get all of my PDF notes, including this video and all of my other videos and playlists. They are available on PDF that you can download and keep for you forever.